Hello, everyone, and welcome back. Today, we're going to be talking about trauma and stress-related disorders. We're going to start by discussing the differences between stress and the stress response. Stress refers to anything that triggers a stressful reaction in our body. While it may sound cliche, different things cause stress for different people. For example, stress can come from a situation like being stuck in rush hour traffic or experiencing a major life transition like graduating from college. Dealing with a health issue, facing a natural disaster, financial problems, relationship difficulties, you get it. The stress response, on the other hand, involves the activation of the autonomic nervous system when we perceive a threat. This response creates a state of arousal and fear, which can manifest physically, emotionally, and cognitively. Physically, fear can cause muscle tension, maybe that's a racing heart or clenching of the jaw or teeth. Emotionally, it may feel like panic or terror or a sensation of a heavy weight on the chest. Cognitively, fear can result in difficulty concentrating or an exaggerated sense of threat, often leading to what's called catastrophizing. So that just means imagining the worst possible outcome. The disorders that we're going to review today include adjustment disorder, reactive attachment disorder, also known as RAD, disinhibited social engagement disorder, other specified and unspecified trauma and stress related disorders. Everyone's favorite here, PTSD, post traumatic stress disorder, and acute stress disorder. These are all very unique, but they do share several key characteristics. So I apologize, this slide is a little bit dark. Instead of symptoms primarily based on anxiety or fear, such as phobias or anxiety disorders, the most prominent clinical feature for many individuals diagnosed with trauma and stress-related disorders are anhedonia, dysphoria, externalized anger or aggression, irritability, and dissociative symptoms, such as feeling detached or disconnected. These symptoms tend to span across different types of disorders that we're going to discuss here. Let's talk about some cultural considerations when working with trauma. As individuals' identities are shaped by intersectionality of various factors, trauma is often influenced by these identities and the environments in which people live. Some key areas where cultural implications should be considered include experiences of refugees and immigrants, disparities in mental health care, especially in trauma treatment, that arise from the marginalization of certain groups, and the impact of racial injustice as a source of trauma. Cultural and linguistic competence is essential, and a failure to fully understand or embrace a person's culture, including overcoming language barriers, can exacerbate trauma. Historical trauma is another important factor, particularly in communities such as Native Americans, youth, LGBTQ populations. So, this intersectionality of identities, including race, age, gender, socioeconomic status, can contribute to the marginalization of individuals, impacting how trauma is experienced and treated. All right, let's shift and talk about the brain. Here we can see an unstressed brain. There is effective communication between the prefrontal cortex, which was responsible for higher cognitive functions, and the limbic system, as well as the reptilian brain in the back there, which governs basic functioning like breathing. This communication allows for tight control over thoughts, emotions, and actions. But on the flip side, that stressed brain, this communication is all over the place. It is disrupted. The control over the thoughts, the emotions, and the action weakens. The prefrontal cortex loses its ability to function rationally. This loss of control can lead to catastrophic thinking and irrational responses. So we often illustrate the stress response in the body through a diagram similar to this, showing how stress is processed by the brain, starting with the hypothalamus. When stress is perceived, the body activates the adrenal system, triggering a cascade of physiological changes. These include increased heart rate, dilation of the bronchioles in the lungs, the liver converting glycogen to glucose, cortisol is released, digestion slows down, blood pressure rises. You can see there's a lot of different things going on here. Essentially, the body is preparing for a survival situation, such as fighting or fleeing from danger. That's where we get that fight or flight response. The autonomic process of the automatic process, of the autonomic nervous system happens in an instant. As we begin to explore the disorders like adjustment disorder, it's important to consider how these physiological responses and the lived experience of the person with these symptoms influences their condition. We're going to start with adjustment disorder. This diagnosis is commonly seen in counseling. This condition occurs when emotional or behavioral symptoms are triggered by an identifiable stressor or series of stressors. These stressor can be a singular event, such as losing one's job, the death of a loved one, or a financial crisis, or it may be an ongoing or recurrent issue like bankruptcy, dealing with the aftermath of a house fire, or struggling with a romantic relationship. So, multiple stressors can also contribute to an adjustment disorder diagnosis. So, unlike PTSD, which has very specific symptomatology, adjustment disorder is characterized by difficulty adjusting to the stressor, with the individual working to return to their baseline functioning. Adjustment disorder is a time-limited diagnosis. Symptoms must emerge within 3 months of the stressor and typically resolve within 6 months after the stressor or its consequences end. For instance, consider a house fire. Once the house is rebuilt and the family is settled, the symptoms of the adjustment disorder probably will subside within 6 months. However, the stressor, if it's ongoing, such as long-term unemployment, the symptoms may persist for longer. This diagnosis is commonly seen in counseling, as individuals often seek help in response to the significant life stressors they may be experiencing. Adjustment disorder is also present, can be present with depressive symptoms, anxiety symptoms, or both. In terms of prevalence and symptom severity, these symptoms must be more intense than what would be expected based on the individual's age, gender, and culture, and the impairment must be significant enough for a diagnosis. Approximately about 5 to 20% of individuals seeking outpatient treatment are diagnosed with adjustment disorder, which is why these stress-related disorders are an important focus here. Let's talk about reactive attachment disorder, aka RAD, which often is associated with childhood neglect and is commonly addressed when working with child and youth services or adoption scenarios. RAD is characterized by a child rarely seeking out caregivers for comfort or displaying minimal response to attempts at comfort. Children with RAD are believed to have limited or selective ability to form attachments, particularly with caregivers. Their response to caregivers is typically minimal, and they may exhibit a diminished expression of positive emotions. Instead, negative emotions such as fear, sadness, irritability, and anger are much more prominent. And children with RAD rarely appear happy or have an ability to self-soothe. The symptoms to look for in a child with RAD include unexplained withdrawal, fear, sadness, and irritability. Children may experience a sad or listless demeanor, and they're kind of just disengaged from life. They often do not seek comfort from others and fail to smile or react positively to a social interaction. They may observe others closely but remain fearful or distant. These children do not reach out for support or assistance and may not respond when picked up or showing no desire to embrace a caregiver. Additionally, they often show little interest in interactive games such as peekaboo. Typically, something along the lines that would promote bonding with caregivers, the child is simply not interested. There are videos out there to show children who have been in orphanages or similar scenarios where there was neglect, and they know that no one's going to respond to their needs. That is often a situation in which a child may develop RAD. Like I just mentioned here, social neglect is a diagnostic requirement for RAD. This condition occurs when a child experiences a chronic lack of basic needs being met, which include frequent changes in the primary caregiver. So, for example, a child who's in foster care or a residential setting, or being raised in an environment with limited opportunities to form healthy attachments. The symptoms of RAD must become evident after the onset of social neglect, and RAD is often comorbid with developmental delays. This neglect can significantly impact brain development and future relationships. Research has shown that early childhood neglect can lead to significant changes in brain development. For example, a comparison of a normal brain of a 3-year-old on the left-hand side there, and then a brain of a child experiencing extreme neglect on the right side there reveals noticeable differences. The neglected child, as shown here, experience severe environmental sensory deprivation, such as not being held regularly or fed on a predictable schedule, and this can result in physical effects like a flat head or bowed legs from being left in a crib or a playpen for extended periods of time. The brain of the neglected child, as you can tell, is significantly smaller. The ventricles, that dark area in the middle, is significantly larger, showing cortical atrophy. These changes reflect not only issues with attachment, but also developmental delays, including delays in emotional development. Abuse and neglect can cause long-term changes in the brain, leading to lasting effects on emotion and cognitive growth. There's a lot going on in this slide here. RAD is a disorder related to attachment and significantly impacts behavior and relationships and learning. So that's what we're showing here. Children with RAD often display clinginess or aggression. They resist affection, and they may have difficulty forming appropriate boundaries. These children typically have a history of abuse or neglect, and while they may be affectionate with strangers, they lack the ability to differentiate appropriate boundaries. In terms of learning difficulties, children with RAD may experience delays in speech and language development, as well as challenges with basic literacy or math. RAD is also can lead to obsessive behaviors such as hiding food due to fears of food insecurity, a result of previous neglect or abuse. For example, an individual who is an adult and they're no longer a child may take food and hoard it, or steal food, or take food from trash cans, things like that, despite now being an adult and knowing that they have access to food. So this food scarcity mindset can really persist, leading to either overeating or hoarding behaviors, things like that. Additionally, children with RAD may develop a fascination with violence, death, or fire, and engage in risky behaviors such as stealing or being impulsive. Behaviorally, children with RAD may experience destructive tendencies towards property or people, demonstrating a lack of empathy or conscience. They may engage in controlling behaviors, resist authority, or show an intense need to exert control over their environment. These behaviors are often seen in children with RAD as a way to cope with their traumatic experiences. RAD cannot be diagnosed in children younger than 9 months. There is limited empirical data on the diagnosis in children older than 5 years. Most research has been conducted on children between the ages of 1 and 5. RAD is considered a rare disorder, affecting only about 10% of children who experience severe neglect. Additionally, there is evidence to suggest that RAD is often undiagnosed. With regard to treatment for RAD, this typically involves psychotherapy for the child, along with family therapy and parent training, particularly for adoptive parents, to help them manage the child's symptoms and understanding what approaches are effective. Special education services are often necessary to address developmental delays. In cases involving violence, residential treatment may be required. Given the challenges of RAD, their caregivers may also be encouraged to seek their own psychotherapy or counseling. It's important to avoid outdated and harmful treatments, such as those used several decades ago that involve forceful or coercive methods like holding the child down or attempting to bend their will. These methods are now considered dangerous and ineffective. Instead, the focus is on healthy interventions that promote attachment rather than punitive approaches that aim to control behavior through force. Some treatment considerations for disorders like RAD focus on creating a safe and stable environment to promote positive interactions and attachment. Goals of treatment include ensuring the child has a secure living situation, fostering the development of healthy attachments, and encouraging growth through nurturing, responsive caregiving. Key treatment strategies involve providing consistent caregiving, creating a stimulating and interactive environment that supports brain development, addressing medical, safety, and housing needs. In cases of neglect, there may also be medical neglect, such as poor dental care or lack of immunizations, so additional services may benefit the child and the family and include individual and family counseling, parent education, parent skill classes, particularly in areas such as discipline. Okay, now let's transition into disinhibited social engagement disorder. This disorder is characterized by a pattern of behavior in which a child approaches strangers or interacts with them in an excessively familiar way. The child may show no hesitation in approaching a stranger and may even go as far as leading unfamiliar adults, which can be dangerous, especially for younger children. So, unlike RAD, where there is avoidance of attachment and a lack of trust, with the disinhibited social engagement disorder, this involves an overly familiarity or an attempt to form attachments with just about anybody. Let's talk about some developmental considerations. For toddlers, there's indiscriminate social behavior, such as approaching or interacting with unfamiliar individuals without caution. Preschoolers, they are attention seeking behavior and a constant need for adult feedback and validation. With middle childhood, there's verbal and physical overfamiliarity or inauthentic emotions being expressed, such as trying the parent or others or attempting to fit in repeatedly. With regard to adolescence, there's an indiscriminate social behavior and social conflicts with peers. Adolescence, especially in middle school, may be a challenging time, and an eagerness to fit in can lead to interpersonal issues. There is also a neglect requirement for disinhibited social engagement disorder, with conditions of neglect often occurring during the first few months of life, very similar to RAD. Current research does not indicate that neglect beginning after the age of 2 is a significant risk factor for this disorder. In fact, children adopted before the age of 2 tend to fare better than those adopted later, as the brain attachment patterns begin to develop at that age. Symptoms of this disorder may persist even after the neglect has ceased, meaning that the child could be in a completely new and nurturing environment and still exhibit behaviors associated with disinhibited social engagement. Some key features of disinhibited social engagement disorder can closely resemble ADHD, particularly due to attention seeking behaviors and impulsivity. A hallmark of this disorder is that the child does not discriminate between caregivers. Approximately 20% of severely neglected children will develop this disorder. In contrast, about 10% of children will develop reactive attachment disorder. Let's transition to discussing post traumatic stress disorder, PTSD, a condition that you probably will encounter very frequently. You can review the DSM 5 criteria, but an individual at risk for PTSD includes those who have experienced natural disasters, physical or sexual or verbal abuse, witnessed or been involved in life threatening events such as military or combat experiences or violent situations. So it's very important to note that many of these experiences are shaped by an individual's perception of the event. A group of individuals can go through the same experience, yet some will develop PTSD while others will not. This largely depends on how the brain perceives the event. Other events that can be associated with trauma include medical incidents such as a heart attack or a major injury, significant losses, the accumulation of small stressors, referred to as little t traumas, which can collectively lead to PTSD. Additionally, secondary or vicarious trauma, which involves hearing about traumatic events or witnessing a loved one's traumatic experience. The hallmark of PTSD is the onset of symptoms following the exposure to a traumatic event. This event may involve actual or threatened death, actual or threatened injury, or actual or threatened sexual violence. Trauma can also arise from witnessing a traumatic event in person, learning about a traumatic event experienced by a close friend or family member, repeated exposure to graphic details or representations of traumatic events. This is particularly relevant for professionals like first responders, child abuse investigators, and even counselors, emphasizing the importance of monitoring for these symptoms in ourselves as well. PTSD is characterized by a range of intrusive symptoms. These include re-experiencing symptoms, which often involve sensory, emotional, or physiological components. Dissociative states and flashbacks can also occur, during which the individual loses touch with reality. In these moments, a person may seem physically present, but their mind is reliving the past trauma as if it's happening in real time. Triggers often precede these intense psychological responses. These triggers can be sensory cues such as smells, specific people, experiences, places. It can be anything that causes the brain to recall the traumatic event. In children, these intrusive symptoms may be expressed through play, where they reenact events related to their trauma. Some risk factors for developing PTSD include temperament, environmental influences, genetic predispositions, and specific genotypes. I realize that the font on this slide is small. I apologize. Temperament, childhood emotional difficulties by the age of 6, and pre-existing mental health disorders can increase the susceptibility of developing PTSD. With regard to environmental factors, low socioeconomic status, limited educational attainment, exposure to prior trauma, childhood adversity or neglect, cultural influences such as self-blaming tendencies or maladaptive coping strategies, low intelligence levels, minority, racial, or ethnic status may also be involved in lived trauma of marginalization, racism, and other forms of systemic oppression, a family history of psychiatric conditions. However, strong social support systems prior to a traumatic event can act as a protective factor against developing PTSD. With regard to genetic and physiological factors, female gender and younger age at the time of the traumatic event are associated with increased risk. Individuals with highly reactive temperaments are more likely to exhibit amplified responses to trauma. Research suggests that younger individuals exposed to trauma are at a greater risk of developing PTSD compared to older individuals. And personality type. Certain personality traits may either serve as protective factors or increase vulnerability to PTSD following a traumatic exposure. Let's talk about peri-traumatic factors, which refer to conditions or experiences occurring during the trauma itself that may increase the likelihood of developing PTSD. First and foremost, the severity of the trauma. The greater the magnitude of the traumatic event, the higher the risk for PTSD. This is particularly true when there is a perceived threat to life, such as I could have died, or personal injury. Interpersonal violence, trauma caused by a caregiver or involving witnessing a threat to a caregiver, particularly in children, is a significant risk. Military experiences from military personnel, being a perpetrator, witnessing atrocities, or killing the enemy can serve as a powerful peri-trauma risk factor. And finally, dissociative experiences during the traumatic event, especially if they continue to persist afterwards, heighten the risk of PTSD. Let's discuss some post-traumatic factors. Temperamental factors involve the individual's internal responses and coping mechanisms after the trauma, including negative appraisals, so a tendency to negatively evaluate oneself, others, and the world. Inappropriate coping strategies, these maladaptive methods such as substance use, drinking to manage stress, could look like a lot of other things too. Development of acute stress disorder. Experiencing acute stress disorder can increase the risk of developing post-traumatic stress disorder. We're going to cover acute stress disorder here in a bit. Environmental factors involve external conditions and exposures to the following traumatic events include repeated exposure to triggers, so being continually exposed to upsetting reminders of the trauma. Adverse life experiences, so experiencing additional hardships or multiple stressful events after that initial trauma. And then trauma-related losses, so facing financial challenges or other losses related to the traumatic event. Social support is a protective factor against PTSD, and a lack of social support or insufficient social connections can significantly elevate the risk of developing PTSD. So let's talk about dissociative states and flashbacks. Dissociative states involve experiences where the individual relives components of the traumatic event, often feeling as though they're back in that moment in which the trauma occurred. Flashbacks are episodes that may include a loss of connection to reality, where the person feels as though the event is happening again in real time. Some triggering cues. Triggers can bring about intense psychological distress and are highly individualized. So, some examples may be a dark bedroom resembling the setting of a trauma. Sudden loud noises can evoke that fear response. Emergency sirens may bring back memories of chaos or danger. For veterans, seeing objects along the side of the road, that's a huge one, might resemble an IED. With regard to PTSD in children, like we talked about before, these symptoms may manifest very differently, and children may express their trauma through play, reenacting elements of the trauma as part of their processing and coping. Oftentimes, there is avoidance, and the person will be avoiding the trigger or even this could be going out of their way to avoid sights and sounds and sensations that may trigger memories. PTSD can involve a noticeable change in mood and cognitive functioning that emerge or worsen following the traumatic event. To meet diagnostic criteria, individuals must exhibit at least two of the following: dissociative amnesia, the inability to recall important aspects of the traumatic event; negative beliefs, so persistent negative thoughts about oneself, other, or the world. So some examples might look like I'm worthless, I cannot be trusted; distorted thoughts, so misconceptions about the cause or consequences of the trauma, often leading to self-blame or blaming others; persistent negative emotions, prolonged feelings of fear, anger, guilt, or shame; inability to experience positive emotions, so a pervasive lack of happiness, satisfaction, or love; diminished interest in activities. This is a notable lack of engagement in previously enjoyed activities. And then feelings of detachment from others, so a sense of disconnection or estrangement from others. At least two of these symptoms must be present to meet the diagnostic criteria. PTSD can also involve marked change in arousal and reactivity, often in response to trauma-related triggers. To meet the diagnostic criteria here, an individual must experience at least two of the following: irritability or angry outburst. This may look like frequent or intense expressions of anger, often out of proportion to the situation; reckless or self-destructive behavior, engaging activities that put oneself at unnecessary risk; hypervigilance, a heightened state of constantly being on guard or alert for potential threats; exaggerated startle response, so an overly sensitive reaction to sudden stimuli such as loud noises or unexpected movements; difficulty concentrating, challenges with focus and maintaining attention on tasks; sleep disturbances, so trouble falling asleep, staying asleep, experiencing restlessness or disturbed sleep. So two of these must be present for a diagnosis of PTSD related to changes in arousal or reactivity. All right, so let's bring everything together. In this slide, we see the pre-traumatic, peri-traumatic, and post-traumatic risks to developing PTSD. If you remember pre-traumatic, that is the temperament, the environment, and the genetics that we've discussed. Peri-traumatic is environmental. Again, remember the severity of the trauma, the perceived threat to life, interpersonal component, and disassociation. And then post-traumatic risk factors. Again, that's going to involve temperament as well, having inappropriate coping strategies, a diagnosis of acute stress disorder, and environmental factors, the presence or absence of a support system, things like that. So as you remember this diagram and you remember these key points when considering PTSD treatment, it's important to take into consideration the full experience of an individual when working with trauma narratives. So let's talk about acute stress disorder, which we briefly touched upon. This involves the development of symptoms within 3 days. That's important. 3 days to 1 month following the exposure to a traumatic event. To be diagnosed, the individual must experience 9 symptoms from any of the following 5 categories. So intrusion, negative mood, dissociative symptoms, avoidance, and arousal. Acute stress disorder often develops into post-traumatic stress disorder. It doesn't necessarily have to, but it often can, primarily depending upon the duration of symptoms. Acute stress disorder is typically diagnosed right after the traumatic event. Like we just talked about in the last slide, it can be diagnosed up to 3 days after the traumatic event. And if the symptoms are treated and resolved, wonderful. That person will not be diagnosed with PTSD, but if the symptoms are not addressed, then the likelihood of developing PTSD does increase. Here we're going to talk about accommodation syndrome, and this involves secrecy, helplessness, entrapment, delayed or conflicted disclosures, and a retractment of statements. These symptoms you can read more about in the DSM-5 occur when individuals exhibit learned helplessness, feelings of entrapment, and poor boundaries. Accommodation syndrome is much more likely to be seen in cases of interpersonal trauma, particularly sexual abuse or domestic violence. Other specified trauma and stressor-related disorders refer to cases where the symptoms are characteristic of trauma but may not meet the full criteria for any of the defined disorders. This diagnosis is often used when the clinician chooses to record other specified and provides a reason for the diagnosis, such as persistent complex bereavement, which may be used in cases of complicated grief that don't really fit criteria for the other disorders. Then we've got unspecified trauma and stressor-related disorders, which are used when the criteria for a specific disorder are not met due to insufficient information. This could occur in a setting like an emergency room or a crisis response situation, such as after a natural disaster, where there just isn't enough data to specify the condition further. So, in this case, unspecified until more information can be gathered. All right, so let's start to wrap up today's discussion. We're going to focus on just some general coping strategies and treatment considerations. So, strategies that are applicable to adjustment disorder and acute stress disorder are particularly helpful when working with adolescents who have also experienced RAD or disinhibited social engagement. So, some of these key coping strategies include spending time with supportive people, engaging in regular exercise, seeking counseling, journaling, practicing mindfulness, making lifestyle changes. Essentially, any healthy behavior that promotes well being can be a coping skill and aid in healing. Treatment for PTSD and related disorders often includes a combination of therapies. These may involve medication, practices like yoga or acupuncture to relax the body and strengthen the mind body connection. Obviously, we would be remiss if we didn't talk about psychotherapy and counseling. Virtual reality exposure therapy is also something very new and upcoming for professionals. Something relatively new is MDMA assisted therapy. This is still very much emerging, and there have been some mixed results lately. There's also medication that may help with nightmares, such as prazosin, and there's SSRIs for anxiety and depression. So you're going to continue to learn about these. EMDR, I am a certified EMDR psychologist, and so I am a very big fan of this. Just very briefly, we're going to touch upon it, but this is a wonderful therapy used to treat trauma alongside with other therapeutic modalities as well, such as cognitive behavioral therapy. So I'm just going to give you the briefest of overviews and then we'll wrap up for today. So on the left side, you can see a brain showing overactivity because of PTSD. That overactivity is like the red color. And on the right is the same brain after completing all phases of EMDR. So as you can tell, there's a lot less red. EMDR involves using both sides of the brain to process the trauma, ensuring that memories are stored correctly and allowing for the replacement of negative cognitions with more positive ones. This technique is something that you hopefully will learn about in future counseling courses. However, it is just a really wonderful treatment that begins by gathering history. Then we do a lot of psychoeducation with the patient. We teach them some coping skills. We may do an assessment to just see what's happening in the body, how the person is reacting to the trauma. Then we're going to look at some new positive cognitions. And throughout the process, we're going to be continuously monitoring the body's response to the trauma. Eventually, we will reevaluate and to see where the person is with regard to their cognitions and how they're feeling. And then we're really going to close out the process of EMDR. So again, that was the teeniest, tiniest little nutshell of EMDR and what it may look like. If you have the opportunity to learn about it or to become trained in that modality, I highly recommend it. All right, that's it for today's lecture. Thank you, and I'll see you in the next one.